Sir, in case of chronic, sir, chronic is modified as more than 3 months, 2 years, sir. In case of chronic, sir, firstly, if we don't did not try steroids, then we give steroid trial, sir. And if not improved, then we you consider DMRD, sir.
Like,
We start with a HCQ, sir. After that, sir, methotrexate, lepulinamide, and sulfasalazine,
okay,
sir.
please,
And with consultation with rheumatologist.
please sit. This is the follow-up.
I've worked in the B70, B8, B71B, and there is PLH production by HL. And
Next. So the patient has recovered completely. Ashwin, what are the complications of chikungunya fever?
So as in this case, it can have cerebralitis, chronic.
Not the neuro complications, other system complications.
Sir, can have chronic arthritis, can have liver failure.
System wise,
Sir,
any other system can be involved.
Sir, it can have pneumonia, sir, in the respiratory system. Like in
Cardiovascular.
myocarditis can be present, sir, in cardiovascular system.
Okay. ENT.
Labyrinthitis.
SNHL. So the patient can present with joint pains, arthritis, respiratory ARDS, cardiovascular ADHF or myocarditis, ocular uveitis, ENT SNHL, very common, gastrointestinal, acute hepatitis, hematological, myelosuppression, and neurological. So Garvita, what are the neuro complications?
Sir, during the infection, there could be a meningoencephalitis. Patient can have myelitis, myeloradiculitis, myeloneuropathy, and patient can have cerebralitis. With the nerves involvement like optic neuritis, then eighth nerve involvement causing the SNHL, and the facial palsy as well.
Okay, please. So today's aim of the presentation was to discuss to discuss the syndromic approach of fever with tropical illness, to sensitize about the unusual neurological manifestations of chikungunya, and to revisit the clinical characteristics of chikungunya with its varied manifestation. Recently, we have done one study in our hospital of 4 to 5 months duration, in which we have studied around 262 patients, including only two CNS complications. Peripheral we didn't study. So there are only two neurological complications. One was this case of chikungunya cerebralitis, second in the literature, and one of chikungunya encephalitis who had a bad, poor outcome in the form of death within 72 hours. I am done with the presentation. Any questions from the residents? The psychiatry residents can get up. Time is up. Any questions? Any comments? Please, sir.
So why did we suspect a chikungunya? Why we did a chikungunya panel in this case?
Because there was an outbreak of chikungunya. So on the very first day, we had done a chikungunya PCR, which was positive, which I didn't show, which I didn't want to reveal. It was actually done on the very first day. It was positive. And we didn't do chikungunya IgM, IgG, the serology. We knew it would come out to be negative. Please, sir. What is it?
Rahil, excellent case and very well demonstrated clinical science and very well discussed. There are first two observations. Once the student said for the orthostatic hypotension that we have to evaluate at 3 minutes, it's 1 to 3 minutes. And most of the clinicians, they would suggest do it at 1 minute and then at 3 minutes, because many patients might actually, who have orthostatic hypertension, they might fall, they might injure themselves. You don't have to wait till 3 minutes. So do the first recording at 1, then at 3. Second, when somebody answered about the definition of FUO, please don't confuse between neutropenic fever and definition of FUO. In definition of FUO, it is 38.3 degrees centigrade or 100.8 degrees Fahrenheit, occurring several occasions for approximately more than 3 weeks, and with whatever thereafter you have defined. In neutropenic fever, it is either one temperature of more than 101 or a 1 hour continuous temperature of more than 100.4. So don't mix up two things. They are two different things. So in FUO, you don't have timing for the fever. It is just that several occasions of temperature so and so. The last important thing. This is very well demonstrated cerebralitis in chikungunya, but the take-home message is, once hereafter, when you start looking at chikungunya patients, don't look for cerebralitis as a first thing. Okay, when you hear of the hoofs, you don't think of zebras, you think of horses. Please evaluate the patient for other things. It's nice that the good clinicians, astute clinicians have picked up this complication, but you should not go back with the take-home message that this is the commonest neurological manifestations for chikungunya. Thank you.
Thank you, sir.
Excellent case and very well managed. Just a small comment. These hyperpigmentation of skin post chikungunya fever, especially on the ala of the nose, is also known as chick sign, CHIK. It is known as chick because it is consistent with chikungunya fever, but not limited to. So the next most common viral infection which can cause this kind of hyperpigmentation is dengue. And the theory behind it is means it is a viral under viral influence, the melanin cannot be dispersed from the melanocytes to the keratinocytes, and there is also a role of UV light. So photo exposed areas show this kind of pigmentation. We had a first-hand experience of a confounding case. We had a case of psoriasis who presented with joint pains. Now, it's natural to think that psoriasis has gone on to involve the joints, and thereby we diagnosed him as a case of psoriatic arthritis initially, but then he developed this pigmentation on the nose. On retrospective history taking, he had a brief febrile illness 3 weeks ago. And consistent with the pigmentation, we revisited our diagnosis.